US in the US. And in particular, the cash and counseling model. I'm a longtime admirer of the German long-term care insurance system, and I first met Matthias when he was the Director General in the Ministry of Health for that. And so we've known each other for about 15 years now. And he actually came as a Bosch Fellow and spent three months with us in, when was it? 2013, I think. And so he really sort of knows the inner workings of my agency from having attended a lot of meetings, and it's a pleasure. I've only just recently met Ben, and then I met Anne-Marie a couple of years ago when she was at the German Marshall Fund. So it's good to see you again, Anne-Marie. So shall I just get started? You want to put the slides up? Or one thing that Matthias wanted me to start out on long-term care in the US, and we do not have, we have social insurance for older people, 65 and older, and for the work disabled people. It's payroll tax funded, the Part A Medicare program, medical insurance, and then we have a kind of different financing system for other aspects of Medicaid or Medicare, the health insurance for older people and work disabled, which some of it's premium funded, some of it's general revenues funded. The payroll tax basically funds hospitals, drugs and prescription drugs and physician services are premium and general revenue funded. Other people have to get their own health insurance, or mostly we get it through our employers, which usually there's the employer pays at least 50%, sometimes often more, and then the employees contribute. And if you're self-employed, you have to buy your own insurance. And we only recently got, something that is close to universal health insurance. We call it Obamacare. And that was passed in 2010. And that also included some expansion of Medicaid to cover health insurance for people who cannot afford private long-term care insurance, private insurance for medical services. Our coverage of long-term services and supports is completely means tested. It's not universal at all. And it's a mixed system between the federal government and the states. Generally speaking, across the national average, federal government pays 60% of the costs and the states pay 40%. There's a matching rate that differs according to the kind of economic situation in each state. The wealthier states pay 50%. In some of the less well-off states, they may only pay 25%. As a result, access to services, long-term care, is means tested, and the means test is pretty strict. It includes both income and assets. And as a result of its being so heavily means tested, a lot of elderly people do not qualify, or they only qualify after they spend down their assets, after they pay privately for a while, and then they can no longer afford. And then they may become eligible for Medicaid. As a result of this, because it's means tested, 50% of the people that get long-term care in the United States are under the age of 65. And these are people who have disabilities that were often acquired either before they turned 18, so they're developmentally disabled, or they are adult onset disabilities that occurred after people reach the age of 18 and were the result of accidents or chronic illness of one sort or another. And those people are more inclined to be poor and to readily um, uh, meet the means test because their work ability has been compromised. In many cases, they either couldn't work or they were not able to earn a lot of money. So that's just the background. So you understand, how our financing system differs from yours. So let's go to the first slide. Okay, so I'm going to focus just on the home and community-based services. I'm not going to talk about nursing homes at all. There are two modes of home and community-based services, and every state offers both. One is formally organized, professionally managed services. The other is what we call self or family-directed services. Sometimes we use the term consumer-directed, which is an optional alternative, which people have to choose if that's what they want. Formally organized, professionally managed services typically involve a service plan written by a case manager and services delivered by formal organizations, for example, aid services that are delivered by home care agencies. That when the services are professionally organized, I should say, there's like there's what we call a menu of defined covered services that the state has said, well, we will cover these services. And the case manager can only authorize something that's on that menu. And then it has to be provided by formal service providers that have signed up to be Medicaid service providers and have been qualified. Self-directed services offer individuals and families more choice and control over the services they receive and their service providers. Typically, paid aides are individuals who may be persons they already know and trust. These can include family members, friends, or neighbors. As of 2023, the most recent inventory that was conducted of self-directed services, about 1.5 million Medicaid home and community services users self-directed their services. Actually, I should say I made a little mistake here. There was not 16% growth rate since 2019, actually 23% growth rate. We really believe that it had been growing anyway, but the pandemic really made it grow. Past research has found self-direction correlates with rebalancing, that is, shifting the reliance towards home and community-based services away from reliance on nursing home care or other institutional services, and lower rates of transition from the community to institutional care. Next slide. Next slide. Okay. These are the permissible uses of self-directed services, employer authority. They can hire individual aides of their choice. Some states prohibit employing spouses, parents, minor children, or other legal guardians, court-appointed legal guardians. During the pandemic, that changed a little bit. They relaxed the rules. Some states are going to allow spouses, parents, etc., which didn't previously. Others are reinstating those prohibitions. Employment of aides must conform to applicable immigration, tax, and labor laws. Non-citizens must be authorized to live and work in the U.S. Hourly wages cannot be less than the state minimum wage. State rates are often higher than the federal minimum wage. Federal minimum wage is still not quite $8 an hour. And a lot of states now have gone to $15 an hour. So you can see the state minimum wage in many states is much higher than the federal minimum wage. Overtime rates must be paid if that's applicable under the Fair Labor Standards Act home care rule. Payroll taxes must be paid. The state pays the employer's share, or the employer's share is included in the budget. Some state exemptions are available to pay caregivers. Payroll taxes cover Social Security and Medicare and unemployment compensation. And those are required. In some states, program participants have some flexibility to determine hourly wage rates. In other states, the state determines the hourly wage rate and benefits if available, and benefits if available, sometimes based on contract negotiations with a union representing these self-directed services aides. And there's unionization in 11 states, including California, Washington, Oregon, Minnesota, and Washington. I'm in Massachusetts. Next slide. Next slide. Okay. Direct cash payments to home and community-based services users or caregivers are virtually non-existent in the United States, unlike the cash for care programs that exist in many European countries. There are no tax-free unrestricted payments made by check or direct deposit to beneficiaries' personal bank accounts. We don't allow cash because of concerns about hiring undocumented migrants, and also the likelihood that if people got cash, they would evade tax requirements and labor protections. Beneficiaries decide how to spend their funds within some restrictions, but all financial transactions occur via an accounting service, which we call a financial management services entity, or sometimes the term fiscal intermediary is used. Again, this is just to make sure that the money actually goes to pay workers and buy services. Paid for by the public program, the accounting service is a key feature of the counseling component of cash and counseling. The accounting service carries out financial transactions according to the beneficiary's spending plan. Most importantly, acting as his or her payroll agent to pay the individual aides that they recruit and employ, and to ensure compliance with tax, labor, and immigration laws. Next slide. Next slide. Whoops. Did we skip one? Go back? All right, yeah. The employer authority is a dominant mode, but the budget authority, this is what we call cash and counseling, is gaining. The employer authority mode remains dominant because it's older. It began in California in 1974. And because California's in-home supportive services program is by far the largest home and community-based services program in the U.S., with a monthly caseload that averages about over 500,000 people, 95% of whom self-direct their aid services. And then this model began to spread to other states in the 1990s. The more expansive budget authority cash and counseling model began as an experiment in the late 1990s. My office partnered with the Robert Wood Johnson Foundation, which is a private philanthropy, to mount that experimental demonstration program. After positive random control trial evaluation findings, it became a regularly available option in Medicaid via regulation starting in 2003 and further expanded via legislative authority enacted in 2005 and 2009. Pre-pandemic, a national inventory estimated 1.2 million self-directing Medicaid home and community services recipients, still nearly half in California. Early results from a new inventory, well, they just came out actually, indicate continued growth up to 1.5 million. And the growth there has been especially for the budget authority. For example, take up the budget authority, the cash and counseling mode, rose from 27% in 2017 to 42% in New Jersey by 2021. Next slide. Prevalence of families paid AIDS varies by state and within states by programs targeting different populations. For example, 65 and older, adult, working age, disabled people, people with intellectual developmental disabilities. In California, in-home supportive services programs, 70% of paid aides are relatives, of whom more than half share a household with the service recipient. And I'll just mention here that a number of years ago, in connection with a study we did in California, we found that, interestingly enough, after the relative that someone was taking care of maybe died, was an elderly person or really, really disabled, or went to a nursing home, there, not the majority, but there was a significant number of people that decided they really liked the work, and they decided to stay in the field and to offer their services to non-relatives. Hiring relatives, especially popular among first and second generation Latino and Asian families. And among the elderly who prefer to employ adult children. For example, in the cash and counseling demonstration states, between 47 and 59% of older people were hiring adult children. Least popular is hiring relatives among the physically disabled adults under age 65. They many times would prefer to hire someone that is not a relative. It makes them feel more independent. Parents are often employed to care for adult children with intellectual developmental disabilities. However, advocates have expressed some concerns that parents' long-term dependency on caregiving income may prevent intellectually developmentally disabled children from maximizing their independence. So that's kind of an issue that we're grappling with. Next slide. What about training to professionalize home care workers? Research indicates that home and community-based services recipients define quality of aid care primarily in terms of relationship characteristics, such as compatibility, trustworthiness, attentiveness, respect, reliability, continuity, not technical competency in performing personal care tasks, which that is typically the focus of formal training. And we'll mention that what we call cultural competency is another issue. A lot of the people who are program participants are foreign born themselves. They came as immigrants to the U.S. and they want to hire somebody often who speaks their native language and who knows their customs, can cook the kind of food that they're used to, and so forth. Agency aides do receive more formal training. However, individually hired aides, family and non-relatives, are more likely to accompany service recipients to doctor visits and to be given information and instruction by doctors and nurses. State Nurse Practice Acts allow them to be trained to perform routine skilled nursing tasks. Some Nurse Practice Acts also allow nurses to train non-relative aides who are hired directly by self-directing services program participants or their representatives to perform skilled tasks under nurse delegation rules. Required formal training for self-directed services aides varies by state. In some states, there's none. It's completely up to the individual, the service recipient, the family caregivers to train people or to determine if they need some training and then seek that training. However, at the opposite extreme, we have requirements for 76 hours in Washington state, although the requirements are lower for paid family caregivers. The union is paid to train them, and interestingly, people have 4 months to complete the training, so they can start work, but they have 4 months during which time they have to take the training and pass the certification exam. So that's quite a lot of variation. Person-centered planning allows for customized training for self-directed services workers. Those of us who kind of adhere to the philosophy of self-direction, we think that this is more useful and less costly than a one-size-fits-all standardized training. Because usually the self-directed services workers are really just working for one person at a time. And they're not, unlike agency workers, they don't go see a lot of different clients, a lot of different situations. So it's an opportunity to really focus in on, what kind of help does this person need? And, is there a particular kind of training that this person who's providing services to this other person should, can benefit from? And counselors can help identify such needs along with funding and the sources for training. Next slide. Who's eligible for self-directed services? With few exceptions, anyone eligible for home and community-based services can choose to self-direct his or her services, either under employer or budget authority options. However, eligible individuals who are cognitively impaired must have a designated representative to assist them or act as their surrogate decision maker. Others may choose to name a representative, even if they are not required to do so. They just might feel that they would like this extra assistance, and if they get sick and are out of commission for a period of time, then that person can sign the paychecks or sign the timesheets and help them out. Representatives are typically close family or friends. They cannot be paid for serving as representatives, and they may also not be hired as paid aides if they're serving as representatives. Virtually all program participants with intellectual developmental disabilities have representatives. A majority of older Americans have representatives, either because they require it or because they prefer to designate one to help them. And a minority of physically disabled adults under age 65 have representatives. Next slide. Needs assessment and benefit determinations precede being given the option to choose self-direction. So prior to having this choice, all HCBS applicants receive an individualized in-home needs assessment to determine their eligibility for benefits and the amount of coverage they're going to be authorized to get. The assessor, who may be called a case manager, administers a standardized needs assessment instrument, and scoring determines the benefit. The benefit may be in terms of a fixed number of authorized hours of aid service per month, or a monetary limit on spending that can be used for a range of home and community-based services. Even when state benefits are generous, paid care rarely covers more than 20 or 25% of the hours of help with daily living tasks that beneficiaries receive, particularly if they're severely disabled. Those who choose traditional formal supports are assigned or may be allowed to choose a case manager who may be the assessor, but more often is someone different. Self-directing beneficiaries exercising budget authority get support from counselors, who in some states are called support brokers or information assistance specialists. Next slide. So how is the budget calculated, and how does this compare to what traditional service providers get? This varies by state, and even within states by programs targeting different home and community-based services populations. For example, age of disabled versus intellectually developmental disabled. I'll just give you one example of New Jersey. The individualized assessment results in a determination of hours of aid service authorized for Medicaid coverage from a traditional agency, personal care services provider for each eligible HCBS recipient. So if the person chooses to go to an agency, then the agency would be paid $24 per hour of aid service that they deliver. This is supposed to cover aid wages, employer's share of payroll taxes and benefits, if any, as well as the agency's administrative overhead. The self-directed services budget, it's the personal preference program, it's called in New Jersey, is calculated based on $19 per hour. It's less than the $24 paid to agencies because self-directing program participants do not have overhead expenses. Support services, the financial management services entities and counseling are paid separately by the state based on a 12.8% of the budget. So self-directed services therefore cost somewhat less per service user than agency delivered services, basically because of, the agencies have more overhead. Next slide. What's the difference between case management and counseling? Case management has historically followed a medical model. Case managers, who are usually nurses or social workers, assess functional assistance needs and develop a service plan. Implicitly, it's somewhat analogous to a physician diagnosing a patient and prescribing a treatment plan. However, identifying functional assistance needs does not require medical knowledge necessary to diagnose illness. Also, Medicaid does not allow home and community-based services case managers the kind of discretionary authority that's given to physicians. They can only authorize the services that are defined and listed on each state program's menu of covered services, and these may be subject to coverage limits. So they might think in their own, based on their own judgment that somebody needs something that's not on the list, but they're not allowed to authorize that. Counseling is a social model, which recognizes that the purpose of HCBS is to help people with functional limitations live as normally as possible, according to their perceived needs, preferences, and priorities, and to help them develop skills to be more autonomous, not just get into and out of bed or take a bath, but do that on their schedule, not a home care agency's. Next slide. And I'll give you an example of how cash and counseling can enable what the advocates for people with disabilities often call having a life rather than having a care plan. Several years before I became the Health and Human Services Project Director for Cash and Counseling, I had an eye-opening experience. I accompanied a case manager on a home visit in Oregon to two sisters who were aged, they were in their 70s, who were family caregivers for their 55-year-old niece, who was severely disabled from birth due to cerebral palsy. Patty could not walk or talk, but she was very friendly and clearly loved socializing. The sisters complained to me that past case managers had tried to get them to accept respite services to get out of the house and leave Patty with a sitter. They felt condescended to, and they said they didn't want or need respite because Patty was not a burden to them. The sisters' lives revolved around the Lions Club, which is a fraternal order that emphasizes service to the community. They sponsor social events to raise money for good causes. The sisters had a van in which they took Patty in her geriatric chair to club meetings and parties where the men would take Patty in their arms and dance with her, which she loved. They also had relatives living in California, and they would put Patty in the van and go to visit the family in California. Next slide. However, the sisters had difficulty getting Patty's geriatric chair into and out of the van. A son living nearby had helped out until a health problem prevented is continuing to do so. The two elderly sisters were risking injury by doing this physically, putting the Jerry chair into and out of the van. They needed a van lift, but they couldn't afford one. They asked me, why won't Medicaid give us the money they are so willing to spend on respite care that we don't want so we can buy the van lift? They had convinced their case manager, who, shifting into what I call counseling mode, had tried to advocate with the state that this would save money on medical transportation for Patty in the longer run. Medicaid paid for ambulances to take her long distance to medical and dental appointments. And the state's position was, well, we cover medical transportation under the state plan, so we won't authorize it as an HCBS service. The case manager was unsuccessful because these and other handicap vehicle modifications were just not on that menu of covered HCBS. A cash and counseling budget could be used to buy a van lift, but this model of SDS did not yet exist. When I met the case manager, she told me she'd been working on it for a year, and she was keeping really careful accounts about the savings that would accrue to Medicaid. And she thought that eventually she would succeed. But it was one of the things that got me interested in this budget authority alternative, because it seemed ridiculous that the case manager was being paid to argue with the state and prove to the state that this was going to be cost effective. Next slide. What counselors do to support self-directing HCBS users and families. A lot of it is help with paperwork to employ individual aides. Initially, this paperwork can be very daunting, especially when you're just signing people up. It gets better over time, and then people get used to it. They get familiar with the forms, but it is difficult in the beginning. The counselors also check the math in the spending plans that the self-directing program participants develop, to make sure they don't go over their allotted budget. So they remind them to take into account the payroll tax amount, and if it's allowable overtime, that might be required, overtime payments that might be required. They coach service users and families in self-direction skills. For example, they might talk to them about how to interview and screen applicants for aid jobs, how to write an employment contract so that they make their expectations clear. But counselors are not allowed to become directly involved in hiring or firing aides. That's the responsibility of the self-directing program participant and their representatives. They advocate with the state, if necessary, for approval of non-traditional goods and services that address legitimate needs for functional assistance and are cost-efficient and effective in doing so. For example, there was someone in Arkansas who bought a stackable washer dryer for his apartment so that his aide did not have to take the laundry to an outside laundromat that was blocks away. They can help brainstorm creative, if sometimes unorthodox, solutions that rely on neighborhood or community resources rather than formal home and community-based services providers. Next slide. Self-direction has several advantages, but it's not necessarily right for everyone. Self-directing beneficiaries may find the added responsibilities of decision-making onerous. Recruiting and managing individual aides may be especially challenging if they do not have family, friends, or neighbors available to hire or that they wish to employ. People with very severe disabilities may have to hire several aides. And on the one hand, they can schedule them more readily. On the other hand, it's a lot more paperwork burden, and kind of administrative burden on them. Worker registries are among the support services that programs can provide to help self-directing program participants identify non-relatives who are interested in working directly for those in need of aid services and their families instead of becoming home care agency employees. Until recently, these registries were telephonic, but increasingly they're going online. One example is Carina.org, which is available in Oregon. This registry is available in partnership with the union SEIU, representing individual providers. However, elsewhere, registries often operate under other auspices, including consumer or, run organizations, that is, run by people with disabilities and their organizations. Next slide. Advantages of self-direction, better outcomes. A substantial evaluation research literature resulted from the cash and counseling demonstration that included a random control trial evaluation, as well as other studies of self-direction in California and elsewhere, Washington State, for example, comparing outcomes for these programs to the outcomes for formally organized, professionally managed services. On all the dimensions measured, service user satisfaction with services, quality of life, reports of unmet need for functional assistance, incidents of adverse outcomes of poor care, such as bed sores, reported stress and burden on family caregivers, cost of care, etc. The outcomes for self-directing program participants were often better, and they were never worse than for formally organized, professionally managed services. Moreover, reported job satisfaction with pay and working conditions was greater for aides hired directly by self-directing services users compared to agency-employed aides. I mean, there are issues. One of the reasons for the shortages that we're facing is, the pay it really needs to be better. But what draws people to do this kind of work, we find, is that they really enjoy the personal bond that they develop with the service recipients. And that's what it makes it very different from, say, being a grocery store clerk or other jobs that are low income jobs, which in fact, unfortunately, sometimes pay better than aid jobs. But the satisfaction that people get from the relationship is what seems to be the attractive component for people that do this work. Next slide. The rationale for requiring family caregivers who want to provide home care to their relatives but need the income from employment to take jobs outside the home, while others, usually strained, are paid to do the job they would have preferred. This is especially if the hourly wage for alternative employment available to them outside the home is the same or lower. Family members, will take these jobs. U.S. research indicates that most unpaid family caregivers who become paid aides continue to provide additional hours of unpaid care. For non-relatives employed as paid aides, to be asked or even to volunteer to work additional unpaid hours violates the Fair Labor Standards Act. But the Department of Labor agreed that that should not apply to family members. They have a right to provide unpaid help in addition to what they're being paid to provide if they wish. Research indicates that when unpaid family caregivers reduce the total time they devote to caregiving, both when they become paid aides or when others are hired, the decrease is small and is consistent with respite. Next slide. Cost effectiveness is another advantage. Administrative costs are lower when self-directing program participants recruit and supervise individual aides. The home care agency overhead typically accounts, in many case, this is especially for the agencies that cater to private duty, private payers. Overhead often takes up 40 to 60% of their hourly rate, whereas the accounting service and counseling cost somewhere between 10 and 20%, like my previous example for New Jersey, 12.8%. CMS has just recently put out a regulation where they intend to limit Medicaid agency overhead to 20% of the hourly rate. And a lot of people, state officials, they question whether that's going to be possible. Savings can be used by government to serve more individuals and allow for more generous benefits, including better pay and benefits for home care workers, for the same total cost that would otherwise be required to pay for formally organized, professionally managed HCBS. Next slide. Another advantage is continuity of care. There's considerably less turnover among aides when people self-direct their services. Annual turnover among agency workers in the U.S. averages 60%. The agencies are constantly having to recruit new aides. Agency aides are often absent or quit unexpectedly, and agencies routinely reassign aides to other clients for convenience of scheduling and to minimize travel time between clients. One example that I was given a while back, by a family caregiver told researchers that when her mother previously received agency services, the agency insisted on scheduling a morning aide for a minimum of 4 hours, 8 a.m. to 12 p.m. This is very typical that agencies will require a 4-hour minimum block. But her mother with dementia resisted getting out of bed before 10 o'clock in the morning, becoming physically and verbally combative if she was forced to do so. So to avoid this, the agency worker sat on the couch watching television for 2 hours until the mother was ready to get up. In cash and counseling, the family was able to directly hire an ex-agency aide that they liked, who agreed to come on their schedule. Next slide. I think we're coming to the end here. Okay. One other thing I'll mention too, this is my contact information, and I'm happy to hear from you if you don't get all your questions answered today. But also mention that one really good thing I think about this model is that when family members can be paid, you don't have this either or between dropping out of the paid labor force to stay home and take care of your relatives, even if you do get a cash payment or something, but you're still out of the formal labor force. This way, you're taking care of a family member and you're in the paid labor force. So you don't have to explain to anybody when, if you're no longer, if your mother or your grandmother, somebody dies and you want to go back and get a job, you don't have to explain why there's this gap in your resume that you haven't been working. And again, you get, your Social Security credits and all of that stuff because you're employed. And so there's not that kind of conflict between taking care of family and being a member of the paid labor force.